important points you gave. And now I call upon Dr. Mano Ranjan Das for the management of intraoperative and postoperative complications.
Good morning, one and all. Thank you so much, madam, for giving me this opportunity. I would like to start with the major intraoperative and postoperative complication. Surgery which is done always looks good with the competent hands and looks also very easy with competent hands. It's not that surgery is easy. So just a meticulous workup has to be done, starting with the case selection and the type of procedure you want to do it. So mostly the complications are divided into intraoperative and postoperative complications. Intraoperative will cover during the donor preparation, recipient preparation, donor lenticle problems, lens or eye related problems, or AR management. Similarly, postoperatively, graft complications with the dislocations, graft failure primary, graft rejection, graft secondary graft failure, AR related complications having secondary glaucoma, interface debris and problems, infections which is rare, and secondary glaucoma. So we start with intraoperative complication. We can have a placement of corneoscleral rim in the artificial chamber that can be eccentrically placed or can be inadequate size in which it pops up. The scleral rim should be ideally 3 mm or around, so that it helps you to stabilize the button and the artificial chamber. Or if there is partial loss during the creation of the pressure, that also can suddenly collapse the button. Or if it is too tight, then you can get a thin graft or a perforation during the pass. So there are also few problems with the automated microkeratomes, like you can get a irregular graft due to the uncontrolled or the improper microkeratome pass. So it can be thick graft, thin graft, incomplete graft, partial cut, or poor handling of the tissue. So this is the actual picture which shows the thinnest graft here. This is irregular graft, and also you can see the thick and thin, and this is very thick graft. And this is the associated picture which we usually take if you don't get the adequate thickness. And again, coming to the patient. So patient preparation is very important. First and foremost, you should have a very nice block, because to avoid the positive pressure. Wound related proper site of incision or the tunnel creation is very important. It should not be too anterior. Side port, in most of the cases will have vascularized cornea and limbus all around, so it should be very nicely placed so that the intra bleeding should not be there. And tightness of the tunnel. If you make the tunnel, please measure for the beginners. You measure the size. It should be exact or little bit loose enough so that you get through the tunnel very clearly. Iris related problems are always due to the excessive positive pressure or selecting cases which are really too tough for the beginners. So intraoperative bleeding is always chance is there. So you please place your tunnel incision or the side incision in a proper way so that you avoid the intraoperative bleeding, sipping of the blood from the tunnel or the side port. These are the remnants. You can see the remnants of the Descemet's remnants. When you choose a bad case or a very thick posterior stromal scarring, it is really difficult to remove the remnants of Descemet's membrane. Here we could not remove it, so there is a bend in the superior part of the cornea. The infolding of the lenticle is seen. So Descemet's lenticular problems, you can have a upside down. You can see the upside down, so smooth surface which endothelium is stuck, and this is the aphakic which I was doing, and it just fell down. So sometimes it can go inside. So and this is another tissue handling. If your tissue handling is repeatedly collapsed and or it has come out again and again, you are putting, so you can have a primary failure almost like picture in the very first day itself. So it should be very carefully monitored. All is not every time is bad about the dissect. So the very nice study which I have done with depends on the insertion. So once you prepare the button, so that should be properly inserted. So as Vanati already told, the glide taco fold, this is a comparison done by Jodhveer Mehta. So they have just found out that taco fold is almost not as good as glide insertion. So because of this type of good studies, we have shifted from almost taco fold to the various type of glide insertions. And next, is it so bad? You can see another study from the same center, we got it, where they have showed that Busin glide and endoglide is always better again, but the cost is the factor. So difficulty coming next to the air part of management. So inability to maintain the complete airfill can be due to improper case selection. So it can be intraoperative complications like severe positive pressure and PCR or vitrectomy, which you can encounter during the surgery, or pre-op you have, when you have selected a hazy cornea stromal, you do not know, you suddenly discover the vitreous there in the AC. Or it can be due to the pre-op morbidity. So if you go ahead with your experience, you can do all these relatively difficult or relatively contraindicated patients, but anyhow you can also get through the surgery very well with experience. So lens problem is mostly when you attempt to do a pseudophakic cases referred to you, you hardly see whether it is ACIOL or PCIOL. Please, you have to look for the proper centration of the ACIOL. I personally feel ACIOL doing surgery is challenging, and again, if you do a primary surgery, please try to overcorrect the lens with a hydrophobic lens. That is the take home from that slide. So pseudophakic, again, mostly we choose hydrophobic lens, and if you choose this hydrophilic lens, then you will have this hydroxyapatite deposits on the lens. So next, coming to the postoperative complications. This is all as you grow mature with your surgery, you try to do something little bit challenging cases, so you can land up in post-PKP case, which I have shown it. So next day the lenticle was in the AC. So please take care of this, and main causes of this dislocation will be the poor endothelium function of the tissue, or the viscoelastic at the interface, or it can be inadequate airfill, or you are having a interface fluid or eye rubbing by the patient. So reposition can be done with the next immediate post-op. So this is a cleft again, showing this cleft where it is, and there is a edema, focal edema. You can see this is a edema here down, and there is a cleft, and there is a oral cleft. The different type of degrees of cleft I can show you. These are the different type of clefts you get in the different type of thickness, irregularities. These are all like learning curves, and this is actually almost is a common drawback of DSEC. So please be very vigilant for the amount of this cleft you have got, and depending on this you have to take a call for resurgery immediately. So primary failure mostly is iatrogenic, and you have to take a call only after 2 months. Okay. Then the graft rejection is very rare, but you can see the line here, but it is always, even though it is rare, it is much safer than the PK surgeries. So coming to this study, this is a very nice report in 2009, which they have all told about the goodness of the DSEC and why this DSEC is more prevalent over the PK. And this is another study which shows the survival of the endothelial cells, and the main thing is that the increased failure, you have to say, think that increased rate of secondary failure with the eyes with previous glaucoma surgery, and after 6 months the endothelial cell loss stabilizes in the DSEC patients. So post-op hair complications can be pupillary block or can be Ugate syndrome. I have shown a pupillary block, hair is blocked there. So incidentally in all cases I do a inferior PI, and interface problem, same thing, Descemet's membrane residual, and these pigments are there to show. And infection, although is very rare, it's almost like fungal infection, and you can see the surface dendrite. And this is a peripheral melt with secondary infection, and this also, sometimes we, after dissection, taking a bad case, we have a 360-degree bullous keratopathy, and if it is not taken care of, then it will come with the presentation of secondary infection at the. So iatrogenic is very, glaucoma is also has to be given importance. Mostly it is by steroid responder or secondary occlusor when you take up difficult cases, and chronic inflammation. So how do you know to prevent? Please select cases with no stromal scarring to begin with. Deep AC should be the criteria. Round pupil, no pass, no vitreous in AC. Adequate tunnel size, at least it should be 5.5 millimeter. Donor tissue selection be now there is no dearth in getting the donor tissue should, to start with, you should at least check 2,700 or 3,000 cells type of tissue you select. Surgeon choice is always important type of insertion. Whichever you are comfortable, please do it on your hand. It will be good. And the take-home message from this is that the 60% of the endothelmic keratoplasty is now being performed. It is a growing trend in India. To proper case selection to start with, so that it doesn't frustrate you. The relative contraindication should be only managed by the senior surgeons. Insertion technique should be chosen only with the surgeon's comfort, and good selection of the tissue is bare need. Thank you. Thank you for the kind attention.